I'd like to introduce our keynote speaker for today. We chose, and she was kind enough to agree to participate, Dr. Kelly Bryant. She is Associate Professor of Nursing at Columbia University Medical Center and the Assistant Dean for Clinical Affairs and Simulation Center. Dr. Bryant got her bachelor's degree at SUNY Stony Brook, and also her master's degree at SUNY Stony Brook. And she got her doctorate of nursing practice at Case Western Reserve University, where I might add my wife got her master's degree in nursing and nurse practitioner, also from Case Western Reserve. Dr. Bryant has done many things, too many to list all of them. I would point out a few things. She has a number of honors and awards, including the Faculty Member Excellence Award, a Crane's Notable in Healthcare Award, the International Council of Nurses Advanced Practice Nurse Education Excellence Award, and a citation from the New York Assembly for community service. She has had a number of grants, mostly as the principal investigator, dealing with simulation, including a large simulation lab proposal to the Hearst Foundation, and grants also about clinical matters and community issues, including issues of drug abuse and vaccine safety, hesitancy, and confidence. She has many peer-reviewed publications and book chapters on a variety of topics, both simulation and clinical. Of particular note for today's symposium is the paper that I read after reading her CV, which is authors Miller, Bryant, and Park, and it's entitled "Moving from, quote, safe to, quote, brave conversations committing to anti-racism in simulation," which appeared in Simulation in Healthcare in 2021. This was a significant and I think very meaningful commentary on a paper that also appeared in Simulation in Healthcare, entitled "Recommendation and Guidelines for the Use of Simulation to Address Structural Racism and Implicit Bias." And I would venture to guess that among the many things she will discuss today will be some of this topic as well. So without any further ado, I'd like to turn this over to Dr. Bryant, and we look forward to hearing what you have to say.
All right. Well, I first want to just thank you for that wonderful introduction. And I'm just going to get my screen ready. Hold on one moment. As I prepare my presentation. Okay, can you see my presentation?
Yes, Kelly, it's fine.
Perfect, thank you. All right, so again, depending on where you are, good morning, good afternoon. Right now in New York, it's about 11:45. And it's a pleasure to be here. And I just want to thank, first of all, Susan Eller and Dr. Gabb and the rest of this CISL team for inviting me here today for this keynote presentation, which is very important to me. And as Dr. Gabb has said, I also, besides being the Dean for Simulation, part of my role is also to promote an anti-racism curriculum and also engage our School of Nursing into activities that help give back to our community, particularly focused on anti-racism. So I just wanted to give you a little bit of background about me, my lived experience, and where I'm coming from, just so you understand a little bit more about why I'm really passionate about this work. Here's a picture, and you're probably gonna say, why is she showing this picture? This is a picture of my high school. my high school yearbook picture, one of the pages, and most of the pages look like this. I come from Albany, New York, which was 91% white and only 4% Black. So I came from a neighborhood where I was one of a few, and there weren't many people who looked like me. And unfortunately, during these times, I did experience quite a bit of racism growing up. And then I had a culture shock. About 10 years ago, I moved to Harlem, where it's absolutely the opposite, where there's only 9.5% white and mostly Black and Hispanic. So I felt like finally I belong. Finally, I'm around people that look like me. And that has been where I've lived for the past, again, 10 years, and where I actually work too. I work in Washington Heights, which again is a very diverse neighborhood, unfortunately very underserved. And this is why it's important to me. I am so passionate, again, about the work that I do and using my simulation center to also give back to this community. One of the things I love about my job is my ability to bring in people, youth from the community, and expose them to nursing, get them interested in nursing with the hope that eventually maybe they'll choose nursing as a career. So we have them come in for about 2-hour sessions where we put them through simulations, we teach them about the nursing profession. And so those are some of the things that I really, really love about my job. In addition to serving on anti-racism task force for the university, working on a committee for President Bollinger, and also being the chair of Columbia's Anti-Racism Community Service Committee. So that's enough about me. So we're going to get into today's topic, which is fostering the next generation of health equity advocates. And so the objectives of this talk, what we're going to kind of cover is, number one, discuss the effects of racial disparities, implicit bias in healthcare. I think it's good to go back to understand, why are we doing this? Why are we having this talk? What are the reasons that it's needed? Demonstrate strategies to mitigate bias, because I think we do a lot of talking about it, but what we don't do is empower our students to what do they do about it? Our students are not assertive enough when they're in these clinical settings. And I hear it all the time. They see horrible things happen in a clinical setting, but they don't know what to do or how to address it. So we're going to cover some things that we can use ourselves, but also techniques we can teach our students and our learners. And then lastly, I am an educator at heart. So I'm going to go into how do we identify educational strategies, and not just simulation. We're going to talk about clinical also and didactic, that we can implement that'll help promote health equity for all healthcare professions. Although I'm nursing, again, a lot of this could be for medicine, OT, PT, dental, so any of the health professions. So we're going to break this into kind of 3 components. The first one is kind of understanding the problem, the why. Why are we doing this work? Why is it important that we do this work? And again, not just focusing on simulation, but taking a more holistic approach to how we really prepare those advocates to identify and understand the problem. And then we could get at discussing strategies, both at the institutional level and at the individual level, on what we could do to combat health inequities. And then lastly, we're going to talk about how do we prepare these health professions to be allies, not just to identify it, not just to be knowledgeable about it, but also what can they do to combat it and also be an advocate. So some of the first things, just going over some statistics. When we look at our healthcare system, we know that it's not diverse. And one of the first things that all of the accrediting bodies will say is that we need to work at creating a more diverse healthcare system. When we look at physicians, for example, 64% are male, 56% are white. This is from a 2019 survey. When we break it down even further, only 6% are Latino, yet Latinos make up 19% of the population. Only 5% of physicians identify as Black or African-American, although we make up 13% of the population. So there's work that needs to be done because we're not reflecting our population. And we know that our population is becoming more and more diverse over the years. And then when we look at other professions outside of medicine, when we look at NPs, PTs, OTs, most of them are female, but again, only 25% are non-white. And just to dig, because I am a nurse, to look at nursing and specifically, Black Americans, again, 13.6% of the population, but only 6% of the RN population. Only 11% of students, nursing students going for the bachelor's degree are African-American. Even less when it comes to when we look at the doctoral level. And then let's look at the people that are educating our nurses, the faculty. Only 9% of them are Black. So we have, again, some work that needs to be done. So this next slide was an interesting video that I happened to just find literally on Saturday, and I thought it would be a great addition to add to this presentation. So let me see if it will play. This is a good explanation of the why.
Here's why Black doctors are so important. There's a 50% reduction in Black infant mortality rate with Black doctors, and Black men are more likely to be compliant with diabetes medications, have cholesterol screenings, get the flu vaccination, and they may have a 19% reduction in cardiovascular mortality with a Black physician.
So very interesting, because, and again, I don't know if you saw, a lot of these studies came from Stanford. And this is not just doctors. I would say this would probably be the same if we were looking at NPs or any other healthcare provider. So the question is why? And as you could see, those statistics were significant. And the reason is, when we're patients and we look up and we see someone that looks like us, that makes us feel more comfortable. That makes us have a better sense of trust. And we know that compassionate healthcare professionals provide better patient care because they bond and trust with their patients by making them feel more comfortable. They help reduce their fears and their stress. And this results in improved care and quality and overall health. More likely to go and get those preventative screenings, more likely to follow those prescribed regimens for your health. When again, you could look at a provider and you could trust that they're doing it in the best interest.
Here's why Black.
So again, some of the reasons why it's so important of having a diverse healthcare system. It promotes health equity. It improves patient outcomes and quality of care, as we've seen from that short video, and improves patient-provider relationships, and it ultimately decreases racism. Again, our population is changing, our country is changing, becoming increasingly diverse. And so we need to work on making our workforce to represent that. And people of color are more likely to provide care to underserved populations. They're more likely to conduct research on issues that are important to their communities of color. And they're more likely to advocate for policies and resources that support underserved communities. Let's look at our educational system. We know historically and present day racism impacts recruitment, retention of people of color into our health professions, starting with getting them in the door when it comes to our education. And some of the main barriers to creating this inclusive instructional environment is the lack of diverse faculty, the lack of knowledge or skills in teaching content, lack of engaging teaching practices. And one thing we need to really look at is our admission practices. If we're trying to recruit more people of color into these professions, what are those barriers that are preventing them from entering and getting accepted into program? And some of that is highly restrictive admission process, depending on these standardized tests, which we know have bias in themselves, and not taking a more holistic approach to who we let into our programs. Unfair progression policies. We get students in and we have a high attrition rate. These students are not making it to graduation. And why is that? Financial constraints. We need to have more scholarships and such so that people are able to stay within these programs and afford their tuition. And then let's look at the healthcare system. How does racism and bias affect patient outcomes? And I could go on, but I'm just going to give a few examples of what the research shows. And it's not, I talk a lot about racism, and I want to make it clear that it's not just racism. There's a bias and just health disparities that exist among the LGBTQ community, even among women, among people from different religious backgrounds, people who do not, English is not their first language. But again, most of what I'm going to concentrate is on race because that's where we see the biggest health disparities. But let's look at women, for example. Women presenting with cardiac heart disease symptoms, such as a heart attack, are significantly less likely than men to receive a diagnosis, referral for treatment, and are more likely to be diagnosed as it's just stress or anxiety, which results in them getting not getting a quick response or getting to treatment faster, which we know can increase mortality if we're not getting those treatments for heart attack in a timely manner. Also less likely to be prescribed aspirin, statins, ACE inhibitors than men. Let's look at the LGBTQ community and some of the adverse health disparities they face. They have a higher rate of chronic stress, substance use, asthma, cardiovascular disease, suicide. And a lot of this is related to the legal barriers to getting health insurance and treatments, and also the discrimination they face in the healthcare system. If you're getting discriminated from the time you walk in the door to the looks, the things that people will say, not being addressed by the correct pronoun or name, that will make you less likely to enter the healthcare system unless you're really desperate and really sick. It'll make you less likely, again, to get those preventative treatments that are recommended, which we know without those preventative treatments can increase your risk of being found to have more advanced disease and increase your risk of morbidity, mortality. And then lastly, can mention when it comes to Black community. I'm a women's health nurse practitioner, so this is something near and dear to my heart, but Black women have a 3.3 times more likely risk of dying during pregnancy, and 60% of these deaths are preventable. And when we look at New York City, just came out in New York, that Black women have a 9 times risk of dying during childbirth and pregnancy than white women. So the question is why? If we are 99.9% genetically the same, why do these disparities exist? We need to take a deeper dive. And then we could, like I said, go on when it comes to COVID, when it comes to diabetes, heart disease, we get some of the same findings. And again, we know racism exists. We just had a huge study that was done last year where we interviewed nurses, 5,623 nurses that was collected for the National Commission to Address Racism. And what we find is that people are reporting and experience racism. 75% witness racism in the workplace. 63% of nurses personally experience it towards them. And then when nurses report the racism, little or nothing is done to change it. So that makes us less likely to report it if nothing's going to be done. And it not only impacts the individual, it also impacts patient care, the processes communications for all healthcare providers to each other, to the patients, to themselves. And it really affects patients, particularly historically marginalized patients, by influencing the way that they access treatment, to treatment options they're offered, severely limiting patient accessibility to quality healthcare. And it directly harms historically marginalized nurses and patients because of that internalized racism, the stereotypes, the stigma, the bias, the labeling that occurs, which makes us less likely to stay at our place of employment or just stay stagnant because we're unhappy with our working environment. So let's dive a little deeper and let's talk about the combat. How do we combat these health inequities? And I'm going to talk about it from what can institutions do, but also what can we do as individuals? Because the work does start with us. Before we go into educating others, we need to make sure that we are prepared for these conversations. We're prepared to put on these simulations that address DEI or racism. So as healthcare providers, we need to combat inequities by advocating for changing institutional, economic, political constructs that are barriers to health inequity. To barriers to health equity, I should say. And there's different levels to this. And so I'm not going to go over all these. It starts from the smallest impact. The smallest impact is working on ourselves to the largest impact when it comes to facing health inequities, and that's at a systemic level. So for example, when we look at systemic level, we're talking about what are those policies that we could dismantle that perpetuate inequities, such as limited Medicaid insurance, limited coverage, disparities in school funding. How do we look at our environment? Some of our communities, why is there in the low income communities, we always have the dumps or the train stations or road systems, which cause pollution, which we know leads to asthma. They're always in certain neighborhoods. Let's look at those social determinants of health. How do we eliminate those barriers? How do we talk about, increasing minimum wage? All those are higher level things that we can do that will help deal with health inequities. But then there's community levels, talking about disparities in our resources, even looking at our schools. And then there's things that you could do at the institutional level. And that's looking at our healthcare organizations and examine the role that the organizations play in perpetuating systemic and institutional racism, looking at our practices, our policies, such as admission policies if you're an educational institution, to looking at the way you treat patients if you're coming from a healthcare setting. And it could go as deep as hiring practices of healthcare providers to when we're education, looking at our curriculum. Are we still teaching things such as race-based medicine? Are we using clinical algorithms that erroneously rely on race? And then let's look at our curriculums again. Are we requiring that our students take certain classes that talk about social justice, that talk about race and racism? So again, there's multiple levels. There's not just one answer will fix everything. We really need to attack this from all different levels. And then we need to look at our environment. Are we creating an inclusive environment for whether it's our students, whether it's our employees or healthcare providers, where we're creating that they're respected, that we create a sense of trust, that we make sure that we're being culturally sensitive, that we're focusing on cultural humility, that we are equitable in the rewards and recognition and promotion of our employees, that we have a common purpose and a meaningful work environment, sense of belonging, and access to institution. Do we have all these elements? How do we know if we created this environment? Are you checking to make sure you've created this environment? How do you do that? Part of it is, have you done climate surveys? Talk to the people that work at your facility. People will be honest. And when you do find out that there might be some gaps, some flaws, what are you doing about it? Do you have a plan? When you make decisions at your institution, who's at the table to make those decisions? Do you have a diverse group of people at the table when you look around? And we need to listen, whether it's our patients, whether our students and healthcare providers. They will let you know how it feels for them, their experience at your institution. And are we listening and really doing something about it? Do we have policies in place? Somebody wants to report that they're experiencing some bias, racism. Is there a place to report it? And then what does that process look like when it's reported? These are all things that we need to look at, think about from the institutional perspective. And then institutions, they got to make a conscious decision and put effective strategies in place to commit to recruiting, not only recruiting, but retaining, whether it's students, faculty, or healthcare providers at their institution. And one of the best ways for recruiting is, you can see on the picture on the left, that is a program called SHPAP, Summer Public Health Education Program, which I have the privilege of now being the PI for Columbia, where we're looking at people from under-resourced areas, people from students of color, and putting them through a 6-week summer program where we're making sure that we give them the resources so that they could be successful in applying for these health professional schools, whether it's medicine, dental, nursing, OT, PT, pharmacy, giving them classes, teaching them, giving them strategies for applying, for interviewing. And that these are crucial for increasing the diversity of the student population in these health professions. And we can't just wait for college. We need to start having these programs very early on, middle school, maybe even earlier, to let students know, yes, you can get into the health professions. And again, how do we eliminate these barriers? Then we look at, again, our places of employment, the healthcare providers. Are we making sure that the people that are at our institutions are diverse? And what are we doing to make sure that when we have positions open, that we are looking to recruit people that are diverse? Are we putting these advertisements in magazines or journals that are targeted towards people of color? And we need to be supportive and show an interest in these individuals, encourage acknowledgement, recognition, so that people will stay at these institutions, that students will stay at these academic institutions. We need to have mentorship programs as one of the ways to recruit and retain. And mentorship role is to provide encouragement, support, sponsorship, expose mentees to opportunities for advancement. Do we have these? Are we working with people of color, if they're in faculty, to work on research grants and manuscripts and projects? These are some of the ways, some of the strategies that we can take to diversify our healthcare system. And take a look at your environment, whether you work in an academic setting or you work in a hospital setting. When you look at the pictures on the wall, for example, what do they look like? Are they all these heterosexual, happy, white families like we see on the left? Or do we have various pictures from all different backgrounds, diverse people in our pictures that are on the wall? That shows representation. When you're in a simulation center, when you look at your mannequins or your task trainers, do you have various task trainers or mannequins, various different ethnicities, colors, skin colors? When you're looking at, for us, we use a lot of standardized patients or standardized participants. Do we have different ages, different ethnicities, different abilities when we're choosing our SP? So things to think about when we're looking at how do we promote diversity even within our own institution. And we need to have DEI champions. And DEI champions are people who make sure that we keep DEI at the forefront and it's not just a fad. It's not just something we did after the George Floyd incident and then slowly falls off of our strategic plan. This includes people who are going to make sure that we're developing new and evaluating old policies and practices that promote DEI. Are we developing diversity programs and education of strategies? Here we have even book clubs to look at books such as Medical Apartheid, and we have discussions about it. Every month we have workshops from different cultures, so they're more knowledgeable about different cultures, religion, and such. Support community engagement, that's supporting equity, working with community-based organizations. Are we looking at, these individuals are looking at our curriculum to see where we might have some areas that we need to improve upon, or again, looking to see, are we still teaching race-based medicine? Are we being inclusive in our education? And also looking at how do we recommend and allocate resources that promote DEI initiatives? Do we have grants? Do we have money funding to have experts come in and do DEI training for our faculty and staff? Are we supporting recruitment of Black students and faculty and healthcare providers? And are we ensuring that DEI stays on our institution's strategic plan? And these individuals, they can't just be there when they're to put out fires, when something happens, some race-based issue happens, and they have to find a solution. We need these individuals to be proactive and develop strategies again, so that we don't get to the part where we'll have all these incidents, that we'll be able to prevent those because we have a plan in place. And again, I just want to make mention that, yes, we should have DEI champions. And again, that could be directors, deans, whatever you want to call them, officers, but it really is everybody's responsibility to keep DEI at the forefront. But again, these individuals particularly will just make sure and enforce it. Are institutions incentivizing DEI initiatives? And this is such things as providing specific grants that address anti-racism equity projects. For example, I received a grant to start a small pathway to nursing program for students that are right here in our Washington Heights neighborhood, a 6-week program. Something small, but again, I was so happy and thankful that the university allowed us money to start this 6-week program to try to get more individuals of color into nursing. Are we providing awards and recognitions for individuals that are promoting DEI? A lot of times this work goes unrecognized, but we need this for promotion, for advancement in our career, and make sure that it is recognized and just as important as some of the other scholarly projects that people have. And again, is it being used for promotion and merit? Is it being really recognized? And again, one of the things that I love is, how are we using, if you do have a simulation center, yes, our focus should be on our learners, should be on our staff at our facilities, our faculty, our healthcare providers. But we have some extra time. What else can we do? We have these beautiful centers. Is there anything that we could do to give back to the community? Simple things such as just teaching CPR to the community. If we really want to promote getting more people of color or diversity into our healthcare system, again, reaching back and looking at our local schools and having just programs where they could come into our sim centers and have a fun day of activities where they can come in and participate in a simulation. And at the same time as they're having fun, they are more knowledgeable about your profession, whether that's nursing or OT. Because I can tell you as a youth growing up, I knew that there was medicine, I knew there was nursing. I knew nothing else about OT, PT, because I wasn't exposed to it. So imagine exposing these students at an early age to all of these other healthcare professions that they might be interested in. That is another way that we could promote. And it's fun, by the way. And then DEI training. And I'm going to go further to say, let's go to anti-racism training. And we'll talk about the differences in another slide. And that could be simple things as implicit bias training, cultural awareness. We had one not too long ago giving us education about practices of Indigenous people, where they came in and taught us certain health practices and strategies with dealing with health issues. It was so interesting. Why not having more of those workshops? And then more importantly, mitigating bias and addressing microaggression, taking it to the next level. Besides just identifying and talking about it, what skills or strategies can we provide to someone so that they know how to deal with it, either when they experience it personally or they witness it in the clinical setting. And some of the central tenets of this anti-racism education include identifying one's own privileges and teaching individuals how to deconstruct their own biases, because we all have them. And then what are those actions that counteract systemic racism? What are things as an individual I can do from an institutional level to a systemic level? What are some of those policies? What are some of those people that I might want to vote for in upcoming elections that I know that will promote agenda that's similar to what I believe in when it comes to social justice? Are we having training that looks at the historical perspective to understanding the origins of racist practices and how we got to where we are today? Sometimes you got to understand the history in order to prevent us from repeating it. And it's really important that it's not just for certain individuals. Responsibility should be for everybody at the institution. And that shows that it's a commitment of the institution to anti-racism education, not just a couple individuals. So we talked about at the institutional level. Let's look at the individual level. Take an internal perspective about what can we do in order to become health advocates, in order to become ready to teach our learners about DEI and anti-racism. We got to start with ourselves. And one of the first things is we got to identify our own biases. We all have them, like I said. And what are we doing about them? So I'm sure you all heard of the Harvard implicit association test that you could take. It's a computer program, and it has tests for everything. It can help you identify your biases when it comes to race, to age, Asian, religion, dark skin versus light skin. So I would say that's very eye-opening. So I would encourage people, if you really want to start on this journey, first take this test and identify. And then look at where you are in this perspective at becoming anti-racist. Anywhere from the fear zone, which a lot of people are, and just knowing that, identifying that. Do I have a hard time talking about racism? Do I think it doesn't exist? To the learning zone, where you recognize that it's a problem. I seek out questions that make me feel uncomfortable. I start to understand my own privileges and my own role in ignoring racism. I educate myself to really getting to that last stage, which is the growth zone, that you're actually identifying how you benefited from racism, that you promote and advocate for policies and leaders that are anti-racist, that you sit in that discomfort because it's uncomfortable. These discussions, just even thinking about the role that you may play or thinking about your privileges makes people feel uncomfortable. I educate my peers about racism and how it harms our professions. I don't let mistakes deter me from getting better. So again, taking that internal look to see, where am I in this journey to become an anti-racist? And then I love this quote. It's about, no matter how open-minded, how socially conscious I think I am, how anti-racist I think I am, I still have old, learned, hidden biases that I need to examine. And it's my responsibility to check myself daily for those stereotypes, prejudice, and ultimately discrimination. What are we doing? We got to do the work. So how are we working towards that? And you got to practice by making a conscious effort on a regular basis to decrease our own biases. Are we willing to engage in critical self-evaluation, examination of our biases? Are we looking at ways that we could deconstruct them? Are we looking at people as individuals? Are we doing counter stereotypes, perspective taking, how people might feel that are from these groups that have been oppressed? Are we intentionally seeking out other perspectives on things? And just understand that there's no single training session. There's no one DEI session. It's not a one and done, but it has to be a continuous effort to work on it. And we need to develop those skills if we're faculty and we're educators so that we can lead these difficult conversations. And we need to shift our behavior from a culture and an institutional and organization that requires practice, repetition, and we need to seek feedback. How are we doing? Are we really doing a good job? So I'm going to propose this question. When you look at your circle and you look at, for example, the people you hang out with, or if you were having a dinner party at your house, what does that circle look like of the people you invited? The people that you spend the most time with? Are you very similar? Do you look the same? Do you have a lot of the same beliefs? Research shows that one of the best ways to overcome implicit bias is to have meaningful interactions with people from diverse backgrounds, especially if you're working towards a common goal. So you want to diversify your circle that you hang out with, that you work with. And the goal, what happens when you do that, those biases that you have about individuals as you work with different groups, you realize those biases that I had about X group, they're not true, because I've been working with Sarah and I realized that what I thought about this group isn't actually true, it's false. And it decreases your prejudice that you may have about other people. So think about making a conscious effort to have lunch with somebody who's different, or somebody who just thinks differently than you. I know that usually they irritate us when, they're the one in the room that always has something to say or a different perspective. But think about spending more time with them. Have regular in-person one-on-one meetings with people who are prone to be biased against, who have a lived experience that's different than you. It allows you to learn also about different people's cultures. I love to tell this story. I used to work at a healthcare facility where, again, I came from Albany, not diverse at all, not even diverse with religion. I had no experience with people who were Jewish. And I worked with a woman who was Jewish and I became friends with her. And I remember one day at lunch, she said, "Can I ask you something?" And I was like, "Oh no, here we go." And she wanted to ask about my hair, because as a Black person, I do different hairstyles, I add hair. And she really genuinely just wanted to know why my hair was short one day, long the next day. And I told her, and I wasn't offended because she came from a place of being genuinely curious. But you know what? That opened the door. And I asked her about her wig, because I had heard all different things about why people from Jewish background wear wigs. But she told me the reason. And I was like, this is such a genuine, pure discussion that we're all scared to have. But why are we scared to have these discussions? Because I can tell you, I learned so much. And some of those things that people told me were actually not true. So I was able to dispel the myths that I heard by just having a genuine conversation with her. Let's have more of those conversations. So now a question, and I'm gonna ask for Susan's help. Think of a recent or any incident where you witnessed racism or bias, or you saw someone who wasn't treated well. Think about, what did you do as the observer? And let's be honest, you don't have to put it in the chat, but if you put a chat, did you do nothing? Did you challenge the perpetrator? Did you report the incident? Or did you do both? You challenged the person that was the initiator of this bias and report the incident. So just curious, something that you might have seen maybe in the clinical setting. Because I can tell you personally, I've had times where I spoke up, but back when I was early in my nursing career, I look back and I was like, wow, I should have done something. I've seen some horrible things. And I just sat back and did nothing. So again, in the chat, if you could just put, and Susan, if you can, I cannot see.
Yeah, and another option I think that somebody brought up was nice. That's like, is connecting with the person who was impacted by whatever happened. It's just like that follow-up thing.
Absolutely, that's another good one. You offered support to the person that experienced it.
Yeah. And I think, we've got just a couple answers so far, but people are saying the B is that challenge the perpetrator, and a couple that say challenge the person and reported the incident. So I think,
excellent. I love it. I love to hear that. Excellent. Great. So what this goes to say is, we never want to ignore the situation. I mean, you got to be careful, because sometimes if it's safety involved, you're addressing the perpetrator, and it could be a safety issue. Of course, your safety is first and more important. But a lack of doing something Think about what that tells the person that experienced the racism. That you may be supporting it because you didn't say anything, or encouraging, normalizing the racism. And you can react either during or you can react afterwards. Like you said, maybe just going and supporting that person. But a single action, no matter how big or small you think it is, can change the situation and make a big difference for the person that experienced that bias. So don't, and also, even if you experience or somebody comes to you and says, you know, Susan, this happened to me, don't minimize it. Because so many times somebody will come and say, that person didn't mean it, or maybe you took it wrong. You don't want to minimize it because it makes you uncomfortable. By not recording or not calling out, it sends a message that racism is your problem, not mine. And you can help. Yep,
Kelly, sorry, I just want to interject one thing because you're bringing up such a great point. And somebody said there's a couple of things in there that people brought up, and so I think it's sorry to interrupt. First of all,
it's fine.
The couple of people said, like, you know, you brought something up but nothing was done, or if the person in power ignores it. And so I think that's an interesting thing to acknowledge at this point, and just to say, yeah, because that's hard when people experience that circumstance.
Absolutely. Yeah. And if you come from that group that's privileged, you know, you can help. Even though you're privileged, you're born, it's still a responsibility to recognize the privilege and again, how this can affect somebody of color, how that might make them feel. Just looking at it from a different perspective. All right, so let's get to what can you do about it? This is the piece I think we forget to talk about. And some strategies, and there's multiple, and I'm not gonna go, I'm just gonna go over a few of them. One of them is that I just learned even last year. Open the front door. So one of the things you do when you have witnessed a situation or experience, actually you experience it, clearly state what you observed. The factual observation and avoid judgment. I noticed that you did X, Y, and Z. I heard that you said, express what you think or what you imagine others might be thinking. I think that what you did may make others feel such and such. Express your emotions about the situation. I feel X, Y, and Z. And then most importantly, state what you like to see happen. So I'm gonna give you an example. I did a scenario with our students where we played a video that happened from a real case. And I'm sure if you're a healthcare provider, you heard the situation where you have what's called a frequent flyer to the ED, that person that comes in intoxicated every Friday night and is told to just go sleep it off. Don't really assess the person, you know, even though they may come in with some complaints. And so you give them a report, and we got Johnny, the frequent flyers in bed, such and such. And you hear this. Using this strategy, you could say, I noticed that you referred to Mr. Smith as a frequent flyer. I think that when we refer to patients as frequent flyers, that sends a preconceived notion about the patient. And it may lead to us, the patient receiving suboptimal care, because we already have this premature diagnosis that they're just drunk, they're intoxicated. I feel these actions can be dangerous because that prematurely closes diagnosis and also leads to us not doing anything besides just, again, thinking that they need to sleep it off. I would like to see us refrain from labeling patients and not calling patients frequent flyers and still giving them the care that they deserve as if they're any patient coming through the ED. So just a strategy. And again, you could just other things. Here's another one that I love to teach my students because they'll tell me, Dr. Bryan, I saw this in clinical and I didn't know what to do. And this is a friend of mine, Bart Bailey, taught me this one. You can interrupt if you hear something. And we did another scenario. Let me give an example where we had residents give a report to this attending. Actually, the attending was going on rounds with these residents, and the attending was going to the certain room of somebody who was shot. And he referred to the patient as a gangbanger during the report. So when you hear something like that, you could do something called interrupt, just to interrupt the conversation. You don't have to go further, but just say, excuse me, can you just clarify, did you refer to the patient as a gangbanger? Hold on, can we go back to what you just said? So not the most confrontation, but just to get the person to maybe just stop and say, whoa, rethink what they said. And maybe that'll give them time to really say, oh, you know what, I shouldn't have said that. Question, take it a step further and say, can I ask you why you referred to the patient as a gangbanger? What made you say that? Or we could educate. If you're really feeling bold and you really want to make an impact, I'd like to share a different perspective on why we shouldn't label patients as X, Y, and Z. Or let me share my personal experience that when I hear patients being labeled by this is what happens. Or share any kind of data or facts. And then another one, if you're feeling a little bit more shy, you're not as confrontational, if you happen to be in a room where something's said and there's someone who speaks out against it, back them up and support them. We call that echo. Say, thank you, Susan. I keep on picking on you, Susan. Thank you for saying something. And I support you. And I agree with what you said. So again, 4 different strategies, easy, that we can use. We can teach our students, our learners. And then I just want to address, sometimes we make the mistake, and I've done this myself, where I've been teaching and I say something that is biased also, and I offend my learners. So we all make mistakes, and that's okay. We need to learn from it, and we need to call each other out when we make these mistakes. So if somebody calls you out, what do you do about it? If somebody says, a student, learner comes to you and they were offended by something, just listen to them. How did it impact them? Then you need to go back and reflect to gain a better understanding of the harm that you caused by your statement or your action. And please apologize and be genuine about your apology. Don't provide an excuse. Don't say, I'm sorry for how you feel, but sorry for what you did. And learn. Go back and whatever that thing was that you might have said or done, go back and maybe learn about that topic or behavior. And then follow, if applicable. If you see the person again, maybe you go back and follow with that student and let them know, you know what, I heard you, I thought about it, and I've implemented change. That can make a big difference. And now let's talk about educational strategies to empower our health professionals, students, learners, healthcare providers. As we need to prepare our future and current healthcare providers to be more aware of the problems that exist in our healthcare system and their part in advocating for health equity and transforming our healthcare system. They have power. We need to tell them that. So another question, I'll need your help, Susan. So what are the barriers, if you are an educator in your role, what are the barriers to implementing, whether it's DEI initiatives or anti-racism education, whether it's lecture, clinical, or simulation? What do you think are those barriers? Go ahead and you can put that either in a chat.
I'll let you know as soon as I see this coming up. And Kelly, I really appreciate it because this is kind of getting to one of the questions that we had earlier while we're waiting for the chat to kind of go, is people trying to figure out like, how do we fight some of these inequities in health sciences in the university? So I think some of the responses that we come up will be the barriers, and then like also the strategies. So thank you for bringing this up. Absolutely. And we're going to dive into those strategies next. Yeah, I think it's this is a common response. Faculty and clinicians feel they are too busy to implement. It's like just another training. Or there is a genuine knowledge gap. It's like, what's the first step? Like, how do you take that and what's the best way to do this, right? Yeah. And we hear it all the time. I don't feel prepared to talk about it. I feel uncomfortable talking about it. I come from maybe one of the privileged groups and I don't feel like it's my role to talk about it. Or fear, I don't want to offend anybody because I think I might say the wrong thing. Because fortunately, we live in a cancel society where if you say the wrong thing, people are quick to be done with you. So there is a genuine fear. Right. And the other thing is that, having institutional support is brought up a couple times, like, what is the institutional, like you said earlier, it's like, what is the money going to, what's the time going to, what's the attention going to? So, it's like, where is that support being directed and how are we understanding what that is and what that means, to us as individuals, and what's it portraying to, our learners and our faculty and our students and whoever else. Absolutely. Thank you for that. All right, so I'm going to move on. So reframing our curriculum too is a big task. How many of us are comfortable we talk about social determinants of health. Some of us may have lectures on health inequities or implicit bias, but some of the harder ones are to talk about racism, talk about privilege, because again, it might make people uncomfortable. So it's great if we're talking about diversity and we're talking about equity and inclusion,
But I challenge us, can we take it to the next step and really talk about anti-racism? Because I feel like in our curriculums a lot of times there's little content on that. And this is really that discussion that moves beyond talking about culture, cultural competency is the term people use, and really talk about the impact racism has on patient outcomes, discussing power and privileges and how that affects our healthcare system. And what are those strategies for dismantling inequities in our healthcare system? Those are the deeper discussions we need to have. Are we still, again, when we look at our curriculum, are our case studies, our simulations, or do they have bias in them? Are we feeding into stereotypes in our cases? And I'll show you some examples later. Is it truly DEI or anti-racism threaded throughout our curriculum, or are we just embedding it in this one course? It can't just be in one course, and it can't just be, again, we do it one time, check box, we've done it. Are we teaching our students and our learners strategies to address it, to interrupt things, racism when they see it? Are we looking, again, at our clinical placements? We're going to talk about that. Are we putting everybody in these nice hospital settings where everybody has insurance and these very great neighborhoods where they're not really seeing the effects of social determinants of health? So again, we need to take a deeper look at our curriculum, really examine it. Some examples. How many of us are really looking, taking a historical awareness at the root cause of health disparities? How many of us at somewhere in our education are teaching them about the Henrietta Lacks and the illegal use of her cells, to Dr. Marion Sims, who was doing all kind of horrible GYN procedures on people without consent and without pain medicine? Are we talking about the Tuskegee experiment where people had syphilis and there was a treatment and we weren't giving a treatment? Are we talking about the Puerto Rico contraceptive trials where women died when we were giving them high doses of contraceptive? I didn't learn this until, not in my nursing program, not in college. I learned this probably just 5-10 years ago. We need to talk about this. We're going to really talk about how we got to where we are today and the root cause of healthcare disparities. Give people that foundation so they have an understanding of why people of color don't trust the healthcare system. This is the reason why. Are we talking to people about implicit bias and the roots of it, and to say that everybody has it and how it plays a role in our behaviors and how we treat people? Are we really having those discussions? Are we talking about privilege? How certain attributes associated with privilege, how that affects why certain people have more access to healthcare, education, employment, and housing? Are we talking about racism, xenophobia, sexism, ageism, and how that affects access to healthcare and everything else? Are we talking about disparities in health outcomes and how they're related to social determinants of health? How that environmental toxins, poor quality of care, discrimination, racism, uninsured, how that leads to higher incidence of heart disease, smoking, infant mortality, obesity, substance. We need to have this in our curriculum. In order to promote a future of health equity advocates, when we look at nursing education, medical education, we need new competencies and different types of learning experiences that will prepare our practitioners for these new and expanded roles. They need to understand health disparities, social determinants of health, cultural awareness, trauma-informed care, and how do they screen for social needs and promote social justice? Where is that in our curriculum? And how do we implement it? And we need to, again, empower our learners to advocate for policies and institutional changes, going above the individual level, again, creating that greatest impact. So here's an example, and I think about when you were in school and you were taking a test, or you were thinking about the case studies that were presented to you. If I were to say to you, looking at these pictures, which person has diabetes, hypertension, and not following their prescribed treatment plan? Which picture pops up? If I was to say which person has housing instability and has a diagnosis of schizophrenia, what picture pops to your mind? If I was to say which person is HIV positive, Which person probably doesn't speak English? Or which of these patients is presenting for treatment for bulimia? Okay, someone was bold enough to put the answers in the chat.
Oh, there's a couple of them that put the answers in the
You didn't
chat.
have to put it in there. But just think about when we're creating these case studies, how many of us have done that? Where we use these stereotypes in our case studies and think about what the impact that makes. Or are scenarios examples of stereotyping? While it can be helpful to provide students with common presentations as these, it's imperative that learners are having discussions about social constructs that lead to certain groups of people being at higher risk for disease, avoiding use of stereotypes in case studies. Because what that does, that may lead us as healthcare providers to failure to perform a complete assessment, because we're saying, oh, they're Black, they must have sickle cell. You know, they can't be white and have sickle cell. And misdiagnosis of patients because we see the patients as demographic characteristics versus seeing them as an individual, versus seeing them as the results of our history taking. An example is that white gay men were overrepresented in early reporting of HIV data, likely leading to the lack of recognition of the epidemic in communities of color, because we were so focused on the image of HIV looking like C. So in order to reduce healthcare bias, we need to provide exposures to different diverse patient scenarios and avoid using these stereotypes. And when we look at our education, some of the biases we can avoid also. Eliminating the use of outdated and culturally insensitive terms. And again, I've had to undo this because I was using these terms because that's what I was taught. Drug addict. Instead of drug addict, person with substance use disorder. Yes, longer, but again, it's less stigmatizing and labeling. Or transsexual, how old is that term? Or someone who's transgender. Avoid race as a descriptor. How many times have we heard 34-year-old Black patient presenting with, or make it even worse, 35-year-old Black diabetic, labeling people by their disease. This happens all the time, presenting patients in scenarios by racial causes individuals to already start thinking about assumptions about their diagnosis, and again, premature closure of their diagnosis due to failing to see the patient as an individual again. So, and particularly in vignettes, we seem to only use race when it's not a white patient. So what does that say? You never hear them say 35-year-old white patient, white female. So that simple omission of race in those vignettes implies that white is the norm and everybody else is other. Avoid teaching race-based medicine. I was taught that. I specifically remember an instructor saying, if I was ever to answer a question on NCLEX or any test where it says, which group of individuals is highest risk for any disease, always pick the Black patient. So I thought that it was because of their genes, me as a Black person, my genetics. And we need to dive a little bit deeper and realize that it's not a race. It's the social determinants of health. It's where we live, where we eat, where we play. It's our environment that puts us more at risk for some of these health conditions. We need to teach that. And that goes into the next one. When we create these scenarios, make sure we add diversity and different demographics and situations to our scenarios. Every case doesn't have to be a certain race. Every case doesn't have to be perfect, they're married and have a great social system and social support, and they don't drink and they don't smoke and they don't have any health issues. We need to make sure our patients, they're not all heterosexual. They're not all able-bodied. We have scenarios where the person might have difficulty hearing, or not the same religion. And not only just putting it in there, but doing something with it. How about people that have housing instability or not low income, and we're giving them all these prescriptions and all these treatments, and we know that they are not able to afford it? How do we take it to the next step to make sure that these patients are leaving with a plan that they can actually implement? Not all our patients are certain size. What about the patients who are larger size and all the difficulties they face as a patient in the healthcare system? Look at our mannequins even. All of our mannequins are this certain size. And also, what do we do when we have a patient that doesn't speak English? How do we adapt to make sure that we're providing equitable treatment and not just talking the limited Spanish that that we know, but actually going through the steps to get that interpreter or use an interpreter phone. Let's build those into our simulations and our scenarios. Because greater representation of diverse patients and families in our simulation cases will normalize for students that the diversity of patients and help patients and students develop individualized approaches to patient care. When we're developing these cases too, things to consider. Are there clear objectives? If we're going to put these DEI elements into our scenarios, make sure that we're doing something with it and not just putting it there to put it there. How does the gender, the race, sexuality, culture, whatever you put in there relate to the case? Or how are these factors addressed in a meaningful way? Were there missed opportunities in some of the cases that you already have to incorporate some DEI or culture into the cases that you have? I challenge you to go back and see if you can maybe put that into some of your cases. Are there any training resources that need to be done? Is there a pre-sim assignment? I put in questions about social determinants of health into my scenarios that students have to do before they come in for their simulations. Are the scripts, if you're using SPs, is it vetted for bias and stereotypes? Are they representing diverse patients? And if you're developing cases where you might not be comfortable about the content area, did you pull in somebody, a content expert, to help you design those cases? Things to think about. And again, I'm not just going to talk about simulation or didactic. If you are responsible at your institution for clinical placements for your students, are we making sure we're putting our students into diverse clinical situation experiences? Homeless shelters, community health centers, schools, substance use recovery centers, free clinics, community-based organizations. The more we can diversify these clinical settings, the more awareness our students have about how social determinants of health play a role in healthcare delivery. How they can perform community needs assessment to identify community resources that can help patients with the care that they need. They can identify, through a community needs assessment, identify that food deserts exist. What can be done about it? Are they going into people's homes for individual visits to focus on health education, arrangement of referrals, evaluations, and improvement for health literacy and development of interprofessional care plans? Are they doing service-based learning? Just things to think about, again, to diversify their clinical experiences. And then, of course, my favorite, simulation. Simulation is a great educational strategy for incorporating concepts related to culture, discrimination, social determinants of health. And you could do it in any format. It could be a case study. The bottom one, that's a video that I do. I did an actual video that I play for our students about that case that I talked about. The patient comes in intoxicated. And in the video, the healthcare provider blows it off, tells him to sleep, but the patient is saying, I have stomach pain. My stomach hurts. And the provider refuses to do an assessment because in his mind, you're just intoxicated. I'm gonna give you a sandwich or something to drink and you're gonna sleep it off. And the patient, this is a real life scenario that happened. The patient wound up dying because they actually did have a medical diagnosis. So I took what happened in real life, an unfortunate incident, I built it into a simulation and I built a whole curriculum around it to talk about what could have been done differently. How can you as that healthcare provider, that nurse in the room, could have done a better job at advocating for that patient? And these are ways just to, again, to promote some empathy, to get students to look at it from a different perspective. And to know that, yes, although you're a student, you can still speak up. There's still things that you can do in these situations. You can do screen-based. There's a VR program that I had the privilege of taking playing for myself, where you live in the, you embody a African-American person as a school-age kid to a teenager that comes outside and is being stopped by the police because you meet the description of someone who just committed a robbery, to you going in for a job interview with other individuals who are white and they pass you by because they don't realize that you are there and you're the graduate from this Ivy League school and they assume it's somebody else because you're Black. And I can tell you, putting on that headset, it was a, you know, it could never embody what it's like to walk in somebody's shoes, but that experience did feel real for that time and gave me a different, deeper perspective of what it's like to walk in somebody else's shoes. And that was done through VR. So again, using all these different formats to address health equity or anti-racism. And I want to guide you to, there's great resources out there. You don't have to reinvent the wheel. MedEd Portal has great scenarios that are peer reviewed, that have every resource that you can need, from the PowerPoint to the evaluation tool to how to do it as the educator. And they have a DEI catalog, and they also have an anti-racism catalog. So I would say, if you want to start somewhere, start there. And it's not just for medicine. You could tweak and revise these. It could be for any healthcare situation. And here are some examples of some of the scenarios that they have in their library that you can use in a clinical setting, simulation, or even a didactic. And some of the scenarios that you can focus on, you can have bias towards patients. I've done a scenario where it's a person, Latino woman in labor, and the healthcare provider is being very biased about, she's screaming in pain, and it's just their typical how Latino people react to pain. They're not really in pain, they're just very expressive. And how do we deal with that? Learners experiencing bias. There's a scenario where I'm the healthcare provider and the patient keeps on referring to me as client services and not their doctor because of the color of my skin. You can have scenarios where you're an upstander advocating for a patient, or any that you're providing culturally sensitive care. All different themes, and there's many more. Scenarios around religion considerations, cultural practices around, let's say, death and dying practices that you can build into scenarios. And then just in general, anytime you have these scenarios or talk about race, racism, and class, it's going to lead to a discussion, whether it's in debriefing, but we need to have these discussions, open heart-led discussions about race, because it does increase awareness. It does build on empathy. Empathy causes hearts and minds to change. And then from that, actions and behaviors, the way I might have treated certain individuals could change. These are the benefits of having these tough conversations, creating that brave space to talk about racism, oppression, privileges. We got to name it, and it needs to be addressed. And they're going to be uncomfortable, and we can acknowledge that, but they need to be had. And before we have these conversations, again, these are just tools that you can use. I want to share set the stage and share a mental model. So we like to get in discussions before we even start, to say we need to recognize that we all have biases, that we live in a society that's based on privilege and oppression, and that people face every day due to whether it's race, sexism, religion, or sexual orientation. We need to acknowledge that we all been taught misinformation from when we were in school to what we see on television, or in our environment. And then we want to make sure that we create a no blame, that we agree not to blame ourselves or others for the misinformation we have learned, but more to accept the responsibility for not repeating the misinformation. And some of these you could start with a statement. I'll give you an example of a blanket statement. This group is intended to be a forum for discussion of ideas and for learning about different viewpoints. We're not here to have a debate. We are not here to make sure everyone knows we are right or to debate each other. It's a discussion around diversity. Equity is important to understand that everyone sees and experiences the world differently. What seems to be right in your experience may not be for someone else's. I ask that we all consider different perspectives for the purpose of sensitivity, learning, and growth. So before we start the discussion, here are some ground rules for participating in the group. And I ask that everyone follow. And we have agreement from the group about these criteria, these rules. And please feel free if you want to add any. And so I'm going to give you next slide some of those criteria that you can use that you may want to be blatantly express and state before you start having these scenarios or these discussions. One of them is that we need to be respectful and respectfully challenge one another. Because I'm telling you, when we start discussion, things are going to be said that can stir up some emotions for people. And then we need to hold each other accountable. If somebody says something that's harmful and inappropriate, it's okay to name it and to make a statement that is triggering. But again, not about the person, but about the statement that is made. Be accountable for our own words. Acknowledge words have power, can affect people. So take responsibility for the comments and stories and thoughts that are shared. And it's a dialogue, not a debate, when we have these discussions. To recognize, again, that we all have privileges and that we bring that to the table. And that we use this space to recognize and investigate our own privileges and honor the different experiences that people have and where those privileges give us society positional that influences again, that we may have advantages when it comes to education, healthcare, but it's part of growth. And it's okay. We're going to be uncomfortable. It's okay with being uncomfortable. And we're not going to have all the answers or the right words to say. And share the floor. Give and take there. If you know you're speaking a lot, maybe not speak a lot to give others time to speak. Don't dominate the discussion. Take a step back and invite others. No one is pressured at the same point. We want to hear from everybody, but some people might not be ready to share, not comfortable to share. So we're not going to force people. And that whatever's talked about, discussed. We can talk about the lessons learned, but not the individual's stories that they may tell or things that they may share. And also that you are not a representative of a community. I don't represent every Black woman. And then when we bring up those topics, to not look at me from my perspective like I have all the answers. Okay. Emotions are okay. I've been in these talks where people cry and they get upset. We need to be comfortable with that. So if it's too much, yes, that person can leave the discussion or leave the room, but it's okay. And to be present, there's nothing worse than having these discussions and somebody's on their phone or they're distracted, because what that tells me is not important, that you've tapped out. And then if you are the facilitator of these conversations, what is important to do afterwards, because I want you to, it's a lot. Emotionally, it's a lot. So debrief. Where our simulation is, we know how to debrief. So look at it. What worked? What went well? Is there something I could have done differently? Maybe that didn't sit well. Did my learners walk away feeling comfortable and not upset? And then take care of yourself. You can't pour from an empty cup. So if you find that these things are triggering and it's taking a toll on you, make sure that, maybe you need to step away from having these discussions. Talk to somebody else. And get feedback. You're co-debriefing or have students in there. Get feedback from them about how the session went, how they felt about it, what they could have done better. And do a check-in with your students, particularly if you found that a student might have been very upset. Don't assume that a student that's up, why they may be upset. Ask open-ended questions. Give them the space to explain. And lastly, as I end, I'm going to put a call to action to all of you on this webinar. And again, some notes that I want to end on. Everybody's responsible for promoting equity, not just those DEI champions. Not a one and done, and I've said that several times, that it should be threaded and that this is an ongoing. For me, I talk about this. I still go to webinars, as many as I can, anything about diversity, anything about culture, webinars about racism, because each webinar I learn something new. We need to create an environment where people can be their authentic self. And that includes making that inclusive space and following some of those tips. And know that we are all learners in this journey. I don't consider myself an expert in this field, but I'm just knowledgeable and I'm here to share. And even if you're not going to take on this change in your curriculum, start somewhere. Maybe start by looking at your scenarios you have and making a change there. Or maybe sitting on a DEI committee. Do something, but start somewhere. So I'd like to open it up. I hope I'm okay on time.
This is important. We can restructure time, Kelly. It's okay.
Okay, well, this is my last slide, so I'm good. And it must be because I'm a little under the weather, so I'm losing my voice, so apologies. So I just want to know from you, that I stole this from my mentor. She ends her presentations always with this. I'd love to hear from you. What are your takeaways? Whether it's that aha moment, something pleasant that you, or not pleasant that you learned today during this webinar, something you still struggle to understand, something you don't agree with. It's okay. Like I said, I'm learning, and there's always things for me to learn, or something you strongly agree with, something that you thought was particularly interesting about today's talk, insight, something you didn't expect to learn, or something that you would have liked to know more about. Any of these things, if you could just put in the chat or the question and answer, something that you walk away from this presentation with.
And Kelly, while we're waiting for people to chat, I just want to acknowledge, because we had a couple of people in the chat and in the QA brought up the fact that I think it's a sense of frustration that, like, I try to report these things and then it's either A, not acknowledged, or it's kind of shifted aside, or, the people in power are not responding appropriately. And I think that, like I said, there was a few people that had brought that up somehow or some way.
Yeah. And then I think you also need to look at your institution, if there is a reporting system or who you could go to. So I know in a lot of schools, they have different departments that you can, so-called anonymously report. If it's in a hospital setting, seeing where those places are and making them accountable, checking up on your complaint to see what was done. And if there's no system in place, working with leadership to put a system in place that where things are reported, it's documented what has been done. How has it been addressed? How has it been implemented if there is no system in place?
All right. And I think just a couple things is that, it's like, I think it's good to have a structure about the conversations about racism, because it's like, it is helpful for people to know how to start those conversations. And so some of those things that you wrote with that open slide, open the door, I think was the name of the slide, were helpful, because I think it's nice for people to have, a foundational way of like looking at some of those things.
Absolutely.
And the other one that I want to say is I had a comment or two about is that it's great to have this, you have provided such a foundational thing, and it can give us a foundation to take this into, as you put out some of the other ways that people are biased against, including the gender, including disabilities. And so taking some of this lessons learned, I think it is. And I think it's more of a question. It's like, and how do we include some of those other things as well, too?
Yes. I'm sorry, was that a question? You're just making a
Well, it was kind of a question that I worded really
Sorry.
badly. So if I was in a debriefing, I'd have to go back and say, wait a minute, I said that question badly. Let me rephrase.
But again, it doesn't have to be about black or white. Building those themes into our discussions, into our simulations, into our didactic, and making sure, those cases that we develop have the diversity to address some of those.
Yeah.
So yes, it's not just about racism.
And again, I just want to acknowledge there's a couple of people that really like that open the front door as well. I think that's I think, like I said, when you give people tools that they can use, that they feel comfortable with, it really helps start and engage those conversations. And again, just somebody wrote that empathy is a responsibility of the healthcare practitioner, not the patient. And I don't think we teach that effectively. So I think that's really good. And nice to hear that people are feeling more motivated to speak up, because you've given them a kind of a structure, and like it's a structure. It's not a scaffolding. It's not a cage.
No. And I think that's what's important, because even for me, I went to so many of these trainings and it was just like discussion, examples, it exists. But then I just left there feeling like, but what next? What can I do? So I really appreciate those sessions that give those frameworks. And there's even more. For example, if you want to know, there's an action framework, there's a grit framework. So if you want some more besides open the front door, if you Google, there's different tools that you could take. And sometimes you use these strategies and don't even realize that it's an actual framework. But I do find those most helpful, because next time it happens, I understand how to address it. I have a structured strategy for addressing it. So.
Yeah, and having, like a lot of people said, is like having that in the moment gives you something that you can, like use as a starting point for this conversation. So it's really great.
Mm-hmm.
Well, Kelly, I just want to thank you so much, and I'll invite David to come and send us off to break. But just personal thanks again for just all the wisdom you shared, and we know you'll be with us for the panel. So
Yes,
everybody, if you haven't got your questions answered, there'll still be time.
Well, I'd like to echo what Susan said, and really enjoyed the presentation a lot. And I'm one of those people who probably at best is mostly in the learning zone, and I appreciate being able to learn some more and strive for better. Hopefully, between our upcoming break and some of the conversation that will be happening in our panel, where some of the other panelists will speak, your voice will get a chance to rest. And so look forward to having that after our break.
great.
So we'll take 15 minutes, and then we'll be back at, it looks like 10 after 10. Does that sound correct, Carolyn? Yes.
Sorry, say that again.
We'll be back at 10 after 10.
Great.
See you then.
Well, welcome back, everybody. We're going to proceed on to the panel part of our present symposium this morning. We're going to have the following format. What I'm going to do is we're going to introduce the panel members, and we're going to give Kelly a little bit of a break so that her voice can rest. We're going to let the panel members introduce themselves. They'll give them about 10 minutes or so to introduce themselves, and then we'll have a chance to ask them specific questions. And then we'll open it up to the group as a whole. On our panel this morning, we'll have Dr. Fernando Mendoza. We'll also have Dr. Tom Caruso. You'll hear again from Dr. Bryant, and you'll hear from Dr. David Gaba again. I want to say this has been just a phenomenal experience for me, learning with all of these people. So it's just been amazing. I also have to kind of acknowledge my own either fallibility or vulnerability. It's interesting to me because I've sat on committees with Dr. Mendoza in the past. I've worked on committees with Kelly, Bryant. And so I know part of what they do. And I listen to them, it's like, this is so meaningful and it's so necessary and it's so cool. And yet over the past few weeks of getting ready for the symposium, I found out even more about what they do. And so this has been so enriching for me just to hear kind of the depth and the breadth that I don't normally get to hear when you're sitting in a committee meeting. And so that's why we were going to take the time to have them introduce themselves and then to give you all a chance to ask your questions. We're going to start first with Dr. Mendoza. Dr. Mendoza is the Professor Emeritus of Pediatrics. He's also was the past Associate Dean of Minority and Advisory Programs at Stanford, and he was in that role for 37 years. And he's done some truly amazing things while he was in that role. And so, Fernando, if you would, I'd like you to take, some time to introduce yourselves and kind of expound upon some of those things that you've done so that everybody else can be as geekly happy about it as I am, hopefully. And then we'll let you give your presentation. Just so everyone knows, please use the question and answer of the chat. I would do my best to synthesize the question. So if more than one person has the same thing, you might not hear exactly the words that you're saying, but we'll get close enough.
Thank you, Susan. Let me just say it was a great presentation, Dr. Bryant. I really enjoyed it. Some of my background actually starts 50 years ago. I came to Stanford as a medical student in 1971. I came as a affirmative action student as a group of 10 students in a quota. And it was basically the third class Stanford had of minority students. And that effort occurred principally, unfortunately, because of the assassination of Martin Luther King that led faculty to say we need to do something. So there was a social disruption, so to speak. Civil rights had been going on. But I think the loss of Martin Luther King made the faculty feel they needed to do something different, be bold leaders. And in that context, then we were lucky enough to have a group of students out there that were willing to step up and become physicians. So in my class of 10 minority students, half of us became professors. And I think that started my career both in DEI, but also in the areas of health disparities, particularly those of children. So, I started at Stanford, went through medical school residency here, did a public health degree at Harvard, came back, did fellowship. And then when I started as a faculty member in 1981, I was really interested in the social determinants of health, diversity. And actually, because I was probably the only minority faculty at Stanford, my second year, I became a dean to support students. So that experience, along with eventually becoming the chief of general pediatrics at the Packard Hospital, I'd like to bring that experience to the discussion today, because I think it's really important to view what we're trying to do today in the historical context of these things, of both DEI, but also health disparities and the need for change in our healthcare system. So let me start. Next slide, please. no conflicts. Next slide. So, I think as physicians, scientists, we have to deal with the reality. And here is a reality that's not going to change. It's going to actually continue, which is a demographic shift in our country's population. And as a pediatrician, I've been very interested in this, particularly the fact that as I mentioned, I'm interested in the health of minority children and diversity issues. And therefore, when I saw this graph, it said to me, this is the present, but the future is also going to be quite different. The present today is the fact that half of all the children in the United States are children of color, Latino, Black, Native American, Asian American, and mixed. That will continue so that by 2060, that will be 2/3. And all those children will become adults. You can see this is a graph of the population change that the US Census puts out. The dotted line is the 50% of the population. The red line is the proportion of children of color. You see that crossed about 2018, 2020. Inclusive of that was the fact that 1 in 4 children in the United States currently are children living in an immigrant family, which means that one parent is born outside the US. As you see, that line continues up to be about 2/3 of the population. And indeed, 1 in 3 children will be at that time a child that lives in an immigrant family. And following that will be the adult population. You can see on the right side of this slide that the population of children currently in 2020 shows that Latinos are the largest minority group, followed by African Americans, Asians, Native Americans, etc. But you can then see what that group grows up into, and that is a population that is in the US no longer predominantly white, but quite diverse. And I would also add to this, probably a mixture of multi-race groups. So what does this mean to us? I think it means that we need to prepare both for the present and the future to deal with patients that are not like us, that have different issues and that are going to be challenging the healthcare system even more so than we've had in the past. If we look at the populations of Black and Latinos and Native Americans, for example, they have issues that are really impactful on their health, well-being, and their future as citizens. For example, Latinos and African Americans have only 10% to 12% of the wealth of non-Hispanic white families. That translates into, unfortunately, a poorer healthcare and poorer education. In fact, if we look over the last 30 years, the children that are from those communities have a half standard deviation less in 8th grade math performance than all the other children. So we have these issues that have been now really organized into the arena that we call structural racism. So the fact that we're dealing not just with personal racism, but with systems racism that will impact the health and well-being and success. And so myself as a pediatrician, my life has been, sort of my career in academia, has been to think about how do we make change. And to the degree that we can make change in academic centers, that's great. But we also have to think about how do we make change in communities where we provide better health care and more efficient health care. We understand that our country spends a lot of money in healthcare, and yet we can look at the persistence and perhaps growing numbers of disparities, particularly after COVID. So I bring this perspective to our conference today because I think it is important to say the perspective of DEI is no longer the kind of altruistic thing to do. It's the necessary thing to do because our population has changed. And if we're going to provide quality healthcare, we need to think about it within that context, that we are providing quality healthcare to everyone, hopefully in a cost-effective manner. Next slide. So this is a slide that I've put together that basically represents where we've been and where we are right now in terms of the number of medical school graduates that are underrepresented minority. You can see the slide starts in 1981. I started as a faculty at Stanford in 1981, and then became a dean of minority students, became associate dean of minority advising and programs. And so I've experienced this process over the last 40 years. One of the things you can see is at the beginning, there were low numbers of underrepresented minorities, in this case, Latinos, African Americans, Native Americans. At that point, those communities represented almost 19%, 18.6% of the population. Throughout my career, we and my colleagues across the country worked on making more numbers of medical school graduates from these communities that were underrepresented, the underrepresented medicine. You can see the proportion of increase, which is basically nil for the last 40 years. And indeed, we've made efforts at not just through medical schools, through all kinds of programs. And in fact, if we look at the change in the numbers of the medical school graduates from these communities and the population that compared to their population, in 1980, when I started as a faculty member, that proportion would represent, with 10% minority medical students, a 56% population equity. That is, number of graduates over the number of percent of the population that they represent. 40 years later, that proportion and equity has fallen to 37%. So we are in fact less well off because the population of underrepresented minorities, the communities that they represent, has actually grown, as I've shown you in the prior slide, and yet our numbers in medical school graduates has not. So what does this mean for our healthcare, medical education, and simulation? Well, I believe that if one looks at all the things that we've tried to do over the last 40 years, it means that this is a difficult task to increase diversity. But it also means that throughout this period of time, we had discussions about the need for diversity because we needed to improve the diversity in our health workforce in order to change how we treat patients. So the problem with this scenario is it puts the responsibility on physicians and people of color to make that change. And I can show you here that we don't have that number to make the change that we need to make. Indeed, we have less than we had before. So my concern is that if we do DEI from the standpoint of getting more numbers without thinking about this as a what I would call quality improvement for healthcare, then I think we're going to be in the same spot that we are now 40 years from now. We're not going to have a change. So my concern is how do we make a change? And ideally, in the past, we were really eager to try to make a change by numbers that you see here that we haven't been able to do that. And then also talking about how do we make change in academic centers by bringing on more faculty and making more faculty of color. Next slide. And so that effort, unfortunately, has not been too successful. And as you see here, these are the portion of faculty from 1971 to 2017 from the AAMC, and the categories you see on top here. While there has been an increase from about 12% to double that, 25% of women, and significant increase in Asian Americans, there hasn't been an increase similarly in other groups. African Americans, for example, went from 1.8 in 1971 to 3.5% faculty. And I tell people that when I started in 1981 as a faculty member, there was 0.2% Mexican American faculty, even though Latinos make up 60, or Mexican Americans make up 60% of Latino population. When I retired 40 years later, there was 0.4%. And you can see the other groups likewise. And And moreover, while these are just faculty numbers, it doesn't show the fact that many of these faculty are low, are at the instructor or assistant professor, particularly for the Hispanic and African American and Native American communities. And in fact, the number of chairs, even though 25% of women of faculty are now women, only about 16% of chairs are. What does that mean? That means that change in academia is not going to occur by minorities or people that are women. It's going to have to occur by others that run academia or control our programs, basically, to think about what they need to do to help us make this change. And so if we move from the altruism of doing DEI, because it's a nice thing, the right thing to do to deal with racism and all that, if we move to the fact that we need DEI because we need high quality care, we need to train the next generation of high quality physicians, which to me means that they're going to be healers of people that don't look like them, then we have a long ways to go. This is the challenge for all academic centers. How do we train the next our generation right now, but clearly the next generation of physicians that are going to be healers, physicians that are going to lead and make change so our system gets better. Right now, it's not hard to say that our system is broken. And we see that in multiple ways, as discussed by Dr. Bryant. But I think overall, we're at a tipping point right now where change is starting to happen. And I think this is really important. Next slide. And so as I think about diversity and DEI and the point of this conference, how to use kind of practice simulation, I think about it as a quality improvement issue. So it was noted, how do you improve quality and content and diagnosis? Well, one of the examples was the skin color, rashes. I trained a lot of pediatric residents on how to look at a rash, but most of the literature was not on rashes of skin color that were dark. There are a lot of other agendas. The issue of symptoms of MI in women is different than MI in men. So these are issues that I think need to be brought up and highlighted as important. But I think if we think about diversity, the first thing we need to think about is how do we build relationships with diverse persons? In other words, how do we build a doctor that's a healer? And what I mean by that is, in order to heal, you have to build a relationship with a patient. You have to be able to convince them that you care, that you understand them, you understand their situations, and you're there to help. And at the end of the day, that is really key for us to not only make effective physicians, but also, I believe, in my experience, to make physicians feel rewarded in doing medicine. I think a lot of times when, unfortunately, in my experience, when residents can't connect, they just don't want to go see that patient. And that is, I think, sad and a disaster for our healthcare system. We have to be able to connect with our patients. So this is where I think practicing DEI in a simulation arena can be really helpful, because it's not easy to work on bias and stereotypes when you're in the clinics. But I think if you move it out of the clinics, make it less stressful, less issues of being good or bad, one can learn. And I think this is a key area for simulation, to look at how do you build relationships. The next area, I think, is to help them understand how disparities impact healthcare. Now, it's not just the issues of language, but clearly, not infrequently, unfortunately, the persistence of people trying to relate to a patient in their broken language, Spanish or whatever language they're using, is ineffective and low quality care. And I think if we state that, that will hopefully make more impression in our learners, that quality care means that you have to be able to talk to the patient, but also to get a sense of different cultures and how cultures view health and wellness, and who participates in that. As a faculty member in clinic, I always would talk about who makes decisions in the family for that, with that culture, right? And sometimes is, you know, having grandma come in. And so these are things that can be learned in a impactful way, I think, in a simulation environment. I think also working with gender identity and thinking about issues of structural racism, how that impacts. These are all things that I believe we can do well in a simulation, because we can give time to think about these things. In a clinical arena, because of the pressure to get patients through, we lose that time to be able to think. And lastly, but important, I think, is the inclusive area. Simulation can create teams that are not the same. They're not all going to be the same individuals, the same backgrounds, that is. I think this is a big area that we can improve on. How do we have diverse teams with diverse leaders? Unfortunately, you know, my own experience over time has been sometimes, you know, who you are, or what you look like, can impact, you know, how people listen to you. So I think this opportunity is really one that is should be, you know, the first step, building these kinds of teams that would be effective in working with diverse populations. And so I would end by saying, if we think about DEI as a component of excellence in healthcare, rather than the altruistic thing to do, then I think that brings everybody into the conversation, from the dean to the department chairs, everybody. Because at the end of the day, we can't tout that we're doing excellent care if we don't. Thank you.
Thank you, Fernando, for sharing that. I was reflecting as I was listening to you, you know, kind of like I think, you know, the numbers are low, and then you don't really realize that until you see it. So I really wanted to thank you for sharing that, because I think it's important to get to the why, right? Like to understand, why is this so important, what we want to do. And, you know, when you see that these percentages don't change that much over 40 years, it can be at once either disheartening or choose to be a call to action. And I guess today I would like to get my brain in the call to action frame, because that's what we're trying to do here, is get people to take action. While we're waiting for any questions, I do want to acknowledge you've done a lot of programs over the past, you know, 40 years with minority leadership and getting people engaged in healthcare, much like Kelly was talking about in her program. Is there any one specific one that you can say you had the most success with, or that you're the most proud of? I know you've had a lot, so that's a difficult question.
Well, I think one is in creating leaders, and that's our early matric program that became the Leadership and Health Disparity program. I started that in 1984, and I've had the opportunity to contact some of those students, and some of those students are now professors, chairs, and these were all minority students. We have the, for example, our dean of admissions here, Professor Iris Gibbs, who's a radiation oncologist professor, was one of our students in our program. The head of lymphoma department at MD Anderson, Dr. Chris Flowers, was one of our students. So what that tells me is, and as a pediatrician, I love this, is that we have all these students that are talented, that are human capital for this country. And I think the thing I reflect upon is, you know, when half our human capital are kids, are children of color, we need to make sure that their opportunities are expansive, because that's the future of our country, those children. And I think that, to me, I was very pleased to see that Dr. Bryant was doing simulation things with young people, because at the end of the day, you know, part of our challenge is not just to make the opportunities happen, but to make the vision happen, and the ability to have people see that they can do these things, to be excited about medicine and science, is really key. I tell the people the story that, you know, I became a doctor because in 10th grade, I got called into my high school counselor, who told me for the first time, I heard you wanted to be a doctor. I never heard that, never said that, but I said, why not? You know, and I think that that thing is really important of being inspiring. And many of our kids have to deal with all the things I mentioned, poverty, structural racism, to be empowered to be able to say, you could do this. And just to show them, bring them to the hospital, be able to show they can do CPR. I mean, that's exciting. And so, I think that to me, that excitement, which we did in our early matric program by exciting young minority students about the possibility of being faculty. We've also tried to do this with community college students, which unfortunately, many of our children of color end up because they go to under-resourced schools, that this is an opportunity to say you can do it. And I think, as much as I think about DEI as quality improvement, I think about DEI for our population of children as the economic development of the country, because that indeed is the reality. Half of the kids need to be able to be successful.
Thank you so much. And Fernando, before we move on, I just want to kind of acknowledge this because I think this was such a lovely tribute. And honestly, it just almost brought tears to my eyes. This person wanted to say thank you because they said you were one of the reasons they're at Stanford now. They came to medical school and stayed. And it was hearing your story that encouraged them to apply to Stanford. And even though they had challenges, that you encouraged them and you got in and doors were opened and there was just a lot of opportunities that came up because of the work that you've done. So, I think it's, like I said, it's been a great experience for me to learn the depth and breadth of what you've done, and to hear a personal story like that is just reinforces that again. So thank you so much for sharing both the information and your stories with us. And it looks like David wants to say something, so I'll let him chime in real quickly before we move on to Tom Caruso.
Yeah, I just want to add my own story. I'm very thankful to Fernando, well, for many things, but my primary collaborator in starting simulation back in the late 1980s was one of the early matric students, Abe Deanda, who I'm not quite sure how Fernando figured out that I was starting to work on this simulation thing at the very early stage, but Abe was an engineer, as was I, before going to medical school, and Fernando thought that would be a good fit, and it was. And we probably couldn't have started simulation the way we did without Abe as an early matriculation student, and went on to be a cardiovascular surgeon. So yeah, there's a real personal memory and connection there for what we're all about in simulation today. So thanks.
Yeah, he's now the chair of cardiovascular at UT Galveston.
It's again, it's just this amazing legacy. And so, I'm sure, I hope we express at Stanford enough how much we've appreciate all the pioneering work you've done, and that, your leadership and visibility is so important for so many reasons. I hate to move on because Tom, it's like nothing like, following that story after that, but I'd like to introduce Dr. Tom Caruso, who's a clinical professor of anesthesiology, perioperative and pain medicine. And like I said, during this journey, I got to hear not only some of the legacy stuff that we're doing, but some of the stuff we're working on going forwards. It's really cool. And Tom and I also had an opportunity to bond over doing PhD work. So, that was an interesting part of our story as well, too. So Tom, if you would introduce yourself and kind of share what you're working on, because I think it's very interesting now that Fernando's provided us kind of a deeper why, like what else are we doing and moving forward with that?
Sure thing, Dr. Eller. Like you mentioned, following Dr. Bryan and Dr. Mendoza's excellent presentations, it's hard to follow that Myself, similar to what Dr. Gaba had said earlier, I do not consider myself a DEI expert. I am definitely in that learning phase and understand that I myself and all of us have implicit biases that we do need to interrogate daily. I'm here today on this panel as a educator and a technologist, if you will, someone who's been developing simulation for the next sort of like the next generation. I believe I have a few slides, and with these slides, I'm here to talk a little bit about remote augmented reality medical simulation. And this is brought to you by a program that I helped start and help run with Dr. Samuel Rodriguez and Dr. Ellen Wang, also in the Department of Anesthesiology. Next slide. So I have no financial disclosures, but I will be talking about a nonprofit today called Invincit Kids that I'm a co-founder and on the board of. This nonprofit, as you will find out, seeks to improve access to immersive technologies in healthcare. I receive no money for my role. In fact, I donate to the nonprofit, so I lose money on it. But I think it's an important initiative, and you'll understand why. Next slide. So before we get too into it, there are going into sort of the idea of using virtual reality and augmented realities as additional tools for medical simulation. These have become very popular in the last 10 years or so. I personally don't believe that virtual reality or augmented reality will ever stand to replace traditional in-person simulation. There's something about that that's just so impactful. But I do think in certain scenarios, these can be important adjuncts and tools that can lend itself towards a variety of settings that may be challenging to accomplish during an in-person simulation with traditional mannequins. What's the difference between virtual reality and augmented reality? So virtual reality is essentially using a computer-generated environment. So in the image you see on your screen, you can picture someone in virtual reality seeing computer-generated people. We sometimes call them avatars in virtual reality. And when you interact with even multiplayer virtual reality, you're interacting with avatars of other people. Now, this can be an extremely powerful way of performing medical simulation if you want to create sort of a avatar-based, computer-generated, CGI-based environment that is pretty unique to a typical scenario you want to create. Now, augmented reality offers the benefit of utilizing your real-world environment that you enhance with holographic imagery. So this allows participants to maintain face-to-face communication, and you keep the instructor, the simulation instructor, in very full control of the room. And I'll explain a bit more about that. Next slide. So here's two figures to sort of drive home the difference between the two. On the left, in virtual reality, this is a multiplayer virtual reality environment. You'll see 4 participants. They aren't looking at each other in real life. They're looking at each other in a computer-generated environment. They're all sitting down, as you'll see, because with virtual reality, you always run the risk of tripping or bumping or knocking into a wall. And the environment that they have to use, generally speaking, is pretty costly to create because it's completely computer-generated. Now, on the image on the right, this is augmented reality. In this scenario, what you see is a person standing in their own home. They can still see their own surroundings. And in this depiction, there's a Tyrannosaurus Rex standing in the middle of their living room. Now, what is the advantage of having these holographic assets? And the benefits of that will become clear as we move on. Next slide, please. So, like I mentioned in the beginning, we developed a program, Dr. Rodriguez and Dr. Wang and I, that basically used initially immersive technologies to improve pediatric healthcare. This program is called the Stanford Chariot program. A couple years after we were developing virtual reality and other technologies to relieve anxiety and pain relief, we turned our attention towards the workforce. How can we educate workforce to better care for patients and how can we go to the workforce to help better care for each other. And so we decided to start to build this augmented reality medical simulator. And in the picture here, you'll see an instructor view of our initial beta version. You'll see a holographic patient on a holographic bed with a holographic monitor and a holographic controller. Now, the instructor would see this controller and be able to modulate things like vital signs and the different objects you see. However, the participants who joined the room would not be able to see that controller. They would just see the holograms in their own space. Next slide, please. So to drive home what this looks like in reality in one particular setting, you can see, and we call the software CHARM, Chariot AR Medical Simulator. So in the imagery on the left, you'll see 3 of our beta testers standing around a patient's gurney with what we call a task trainer, which is a chest that you can do compressions on. In the imagery on the right, you'll see what they are actually looking at. They're looking at a holographic patient overlying that gurney on a holographic bed and a holographic monitor. The key points here is that these participants can still maintain eye contact with each other and be in the same space safely. Now, next slide, please. One of the most important aspects of this, to sort of bring it back to our discussion here, is how you can have mixed reality simulations. In this situation, you'll see 2 participants acting on a task trainer, but what they actually see is a patient with a ambu bag that they're masking with, and they have another participant who's doing chest compressions. Although it's on a task trainer, to her vantage point, she sees it as a holographic patient. What I'm doing is offering the participants a real life tangible asset, a ultrasound probe, because in this simulation, they're about to do a ultrasound of the heart to look for fluid around the heart. Now, one of the really cool things about augmented reality simulation is I would like people to kind of think of the Lego model versus buying a real life model of something. So let's say you were to buy a real life model of a football stadium. You'd have that football stadium, you'd have that model, and that's what you see, and that's basically all you can get from it. And a lot of times when you go complete computer generated imagery, such as virtual reality, what has been created is sort of what you get. Now, augmented reality, I like to sort of pitch as the Lego model. So here in this situation, you might be looking at a Lego recreation of a stadium, but you can take apart those Legos. And in this analogy, you can take apart these holographic assets. And as the instructor, you can build scenarios to basically be amenable to anything that you want to teach. So back to Dr. Bryan and Dr. Mendoza's points, let's say we want to do a scenario on caring for children or adults, and they are a different color than the predominant majority of the learners, right? We can create an environment that would put them in that scenario in a way that with traditional simulation, you may have to buy a mannequin of a different race or ethnicity. And in virtual reality, you're reliant on what has already been sort of fabricated in this computer generated environment. Then on top of that, you can go into any environment you want. Let's say in this setting, we're in a PACU, we're in a recovery room doing a simulation, but you can bring these all-in-one headsets into, let's say, a patient room. You can bring them outside and do a simulation like we're doing with the Mountain View Fire Department if they're a first responder to a scene. You can bring them almost anywhere you want. And similar to Legos, once you become facile with the holographic assets, we call them, with the right expertise and folks like Dr. Mendoza, Dr. Bryant, you guys are the true experts in this area. This can be a tool that can be used to supplement traditional education to help push the needle forward. And at this point, people say, okay, why are you telling us about this? This sounds great. Well, next slide, please. We can also do this remotely. So perhaps you guys have considered or thought of in the past that there are some really true experts in the field, like ones we have on the call today, but it's very challenging to be called to go to different environments and have to travel and perhaps go to limited resource settings to do the teachings that you want to do. So we took this software and we developed remote training. And the way this works is, and this is a scenario with using this with Stanford medical students here, this is during COVID, and we are all in the safety of our own home, but this can be done internationally, this can be done across the nation. And in every person's own home, they're seeing the same holographic environment, and they're communicating via microphones across these all-in-one headsets. And so in this setting, you can imagine, like Dr. Mendoza mentioned about different languages and people of different cultures, you can start to break down that distance barrier. So for example, we're doing some work with Cornell and Qatar, looking at basically different impressions that medical students here may have with medical students from the Middle East. And when putting people all in a shared environment, how does that change our impressions of each other? So now we've reduced the barrier to going to these places. And let's say you have the opportunity to go to a place and do simulations. Now that program can sustain by saying, hey, I may not be here physically anymore, but we can hop in these headsets and do trainings in the future. Next slide, please. So because, and just to throw this out there, I also went to Stanford Medical School. And although I left for my training, I returned, and there's always been a core set of values that we really, at least I have really rubbed off on me coming through the system here. And I have always recognized how privileged that I am, not just as a white man, but as a physician at Stanford Hospital and a multitude of other privileges. And for our whole team at the Stanford Charrier Program, we recognize those. So it turns out that, as you guys may know, that when you develop technologies as a Stanford professor, and probably at any of your institutions, those are owned by those institutions. So in order to get these technologies into your hands, we went to Stanford and asked, what's the strategy for that? And typically you have to find a distributor. And so most distributors cost money for their end users. And that just didn't sit well with our core set of values. So we went ahead and created a nonprofit. The nonprofit's called InvinciKids, and through InvinciKids, we're able to license this software to any participants who want it, so that we're able to support all of your very, very important work, get feedback from that work, build out the software to make it more useful for you, and send it back to you. And that's a no-cost license. So next slide, please. And our mission is to increase the access and use of immersive technologies in healthcare settings globally at no cost to the end user. And a nice example, and like I mentioned in the beginning, we try to be as generous and open as possible. And Dr. Cynthia Koo, Dr. Anna Crawford, two international medical experts in our Department of Anesthesiology, have facilitated a relationship with the Foundation for African Medical Education. And just earlier this week, what I was just talking about was actually occurring, where Dr. Cynthia Koo was doing a medical simulation with Tanzanian certified registered nurse anesthetist. So although she's not able to be in Tanzania today, she's able to use these technologies to at least provide some access to the expertise that we hold here at Stanford in a more immersive way. And this is, like I mentioned earlier, this is just one tool. It doesn't obviate Zoom. It doesn't say that tablets don't work. It's not a replacement for traditional simulation. It's just a tool that we're building. And in certain scenarios, it may be helpful for people. So I'll pause there.
Well, thank you, Tom. And anybody, if you have questions, please feel free to put them either in the Q&A or the chat. I've gotten good at multitasking and I can look at both of them. I'm fascinated by the work that you do. I applaud the nonprofit part of it, and that you're, giving access to people that, because it's like during the pandemic, like many people, we evaluated a lot of programs, like what can we do and what can we use? And again, there's costs associated with them. And then the cost, became a barrier to people. So I, really appreciate that you've kind of removed the barrier. The other question that I'd love to explore just a little bit is you talked about the work in Qatar and then about like the the impressions that they had of each other, and it like kind of translate to this notion that we've been talking about, implicit bias. So I wonder what you found, if anything, when you did that exercise.
Oh, sorry, that's a study that it just got approved by the IRB. We're starting that this upcoming spring.
All right, so then I won't ask you about it. No.
Yeah. Well, it'll be very interesting. We also have some Chilean colleagues who are also going to, it sounds like we're going to be able to get them involved as well. And we're just very excited to start to see this. You mentioned getting a PhD. My PhD work is in education through the Stanford Graduate School of Education. And, full disclosure, I have seen similar work outside of medicine in other settings where one of my colleagues in the Graduate School of Education has used Zoom to bring people of different cultures together in a shared learned environment. And, they're in that environment thinking, hey, we're learning how to care for patients. But the secondary benefit to what Dr. Bryan and Dr. Mendoza have mentioned is they actually start to perhaps accept and feel differently about the people in that environment as they start to see them more as the shared human experience that we have, and beyond, superficial impressions. So his work was that was Dr. Keith Bowen. His work was really fascinating, and I was like, we got to try this in medicine and perhaps over a table of simulation.
Yeah, it's really interesting sometimes that, it's like I got so tied on early in my kind of education into like nursing, because that was my background. But it is very interesting when you look at things like, oh, what other things can we learn from education? Or interestingly enough, what are the things we can learn from like electrical engineering, or things that I wouldn't have thought of, people that can bring in this. And especially when you talk about, hey, we can work on things like diversity, or we can, build in these layers. I love the Lego model because, of course I have grandchildren who it's like, it resonated very well with me about like, how do you use these tools, not just as this kind of built thing, but like to structure it. It's
right.
Great.
And I'm not the expert in that area, as I've mentioned several times. And we're really like our strategy and our vision has always been like humility. We have access to these tools. We are resourced, and we are open to ideas. We are open to suggestions. And when we bring these out to different groups, like for example, when we're working at the fire department, they're giving us all sorts of ideas that we would have never thought of on our own. This is definitely a groupthink project. And we want to make sure that everyone has access to it. And, that's where we stand.
Awesome. Thank you so much. All right, Kelly, hopefully your voice has moved on. You've had a chance to recover since we had you talk so much. I wonder if you just want to give a brief introduction of yourself for anybody I think everybody who's here now was at the first part of the session, but again, Dr. Kelly Bryant, and just any other thoughts or insights you've had after listening to either Dr. Mendoza or Dr. Caruso.
I actually put a presentation together too. I thought about it. I just did one for another committee. I was like, wait a minute, I can use this one here. And yes, some ginger tea, so I think I'm better.
Oh, lovely. Glad you had a chance to rest your voice.
Yes. So just to share some of the things that we're doing in our simulation center, outside of course, educating our learners. Can you see my screen? Oh.
Yes, we can.
Okay, that's all I need to know. So some of this I talked about in my presentation, and I guess let me introduce myself again for those who might have joined later on. I'm the Assistant Dean of Clinical Affairs and Simulation at Columbia School of Nursing. So part of my responsibility, the main one is to focus on our simulation center, but I'm also responsible for DEI activities for the School of Nursing, getting our students involved in our community that we serve, and also developing anti-racism opportunities to address health disparities in our community. So some of those you'll see in my presentation. This first one is one I really enjoy doing. It's called the Community Development Resuscitation Education and CPR Training, short for CD-REACT. So I work with the Community Affairs Department and a physician who put this wonderful project together where we go into community-based organizations, schools, anyone who asks for it, and we can conduct everything from CPR, hands-only CPR, not official CPR, Narcan training, stop the bleed, and also just safety training for things such as wearing your seatbelt to why you should wear a helmet. And I love it because we get to work with the kids and they all get their American Heart Association kit, and you see them sitting there and they're practicing their CPR training. And so far we trained 450 people in our community. So sometimes it's on site and sometimes we go actually to their facility to do the training. And it's a beautiful way to get your students involved and give back to the community. We do a lot of health fairs. So we've done 19 since April. We collaborate with our local hospital. And again, people request our health fairs. We do everything from blood pressure screening, health education, to actually dispensing reading glasses, which was interesting. It's great because again, we get our students, and most of these health fairs that exist are in very underserved communities where we find a large amount of people with high blood pressure. So we not only just give them the reading, but we also give them resources where they can go for free health care and to get that that high blood pressure addressed. And of course, my favorite, I use my simulation center to promote a career in nursing. So everything, the left one is the I always say YMCA, but it's the female version, YWCA. They come in every year to do a fun simulation / learn about nursing. That is, again, we had kids learning CPR because we know that kids as young as, I believe they start in 5th grade, can actually save somebody's life from CPR. So that's a group in our simulation center, and the parents were in another room actually. And any school, we have most of our local schools, they'll come in and we put on this two-hour presentation / fun learning activity and have them go through taking care of a 5-year-old with asthma using one of our high fidelity mannequins, so that they not only hear about nursing, but then they get to play the role of a nurse. And I found that that totally motivates some people to consider a career in nursing, and sometimes even change people who were thinking about medicine or something else to think about nursing. We do a lot of interprofessional education with dental and medicine and OT and PT. And it's great for our students because a lot of times we work besides these people, but yet we have no clue what their role is in a scope of practice. So again, great exercises that I enjoy. We do a fun escape room with everyone every year. Talking about promoting DEI, there's nothing more impactful than immersing your students into clinical settings, different countries, environments where they're exposed to different cultures and different patients. So we have about 70 students each year that go to different countries, including Ethiopia, Kenya, India, Gambia, and they have a 6-week rotation. So we prepare them for that clinical experience, both from the clinical skills, but also what the cultural experience of going there, so that when they get there, they'll be more prepared to start their clinical rotation. And then we do a lot of, as we discussed, DEI training. And for example, the one on the right, I love when I team up with the hospital. So the emergency department, we did a joint simulation where we exposed the ED docs to situations where different ones. The one I was in, I was actually the healthcare provider and the patient was being biased towards me. The patient refused to acknowledge the fact that I was their healthcare provider. I was the doctor trying to give him discharge instructions. And he kept on telling me to take out his garbage, take out the trash. And so we had the ED doctor in the room to see what would they do? Would they step up and help me? Would they be that ally, that upstander? And it was very interesting. And we did it about 3 times. I had everything from fully supported me and stood up to let the patient know, no, this is your healthcare provider and you need to listen to people that didn't do anything because, again, they didn't know what to do. So that we've done several of those type of trainings where they get to not only learn about bias, but practice those techniques to mitigate bias. And then we have our annual conference. We have funding to do one once a year. And so we took, 2020 to just focus on dismantling structural racism within our health, with using healthcare simulation. We had great speakers. So each year we pick a different theme, but that was one that was very well attended. And then another, looking at the community, one of the problems we have in our community is we have a very high opioid overdose death rate in the Washington Heights community. So we started our own opioid overdose prevention program where we do training on how to use Narcan. And we train all of our medical students, nursing students, community-based organizations, to community boards, to even the NYPD attended one of my trainings. And so we've been able to train over 2,228 individuals since we started our program in 2018. And we've had 9 lives saved that I know of based on kits that we gave out. And then we have a lot of grants and programs. One of them is we're starting a simulation program in rural India, and we donated one of our mannequins, as you can see there on the left. We do a lot of training. Again, I'm very passionate about pathway programs in nursing, but also opioid overdose prevention, deaths. So we had a training where we trained outreach workers who are on the streets every week, trying to motivate people to get into treatment, people who use drugs. So we gave them training on motivational interviewing. A lot of these individuals had really horrific wounds that required medical treatment, that they refused to go to the local hospital because of the bias and stigma they face. So we were able to train them on basic wound care techniques that they can use when they're out doing this outreach, because the individuals would not go and seek medical care. And so I just found out while I was in this training that we got our funding for $100,000 from SAMHSA to help support our education. So we'll be using our simulation center to support educating more of these outreach workers. And then, as I discussed, the Summer Health Profession Education Program, where we get 80 students from all over the country, first and second year, that are interested in either medicine, dentistry, nursing, physical therapy. They get to stay in our dorms. They take classes. We go over the admission process for the health profession program, wherever they want to apply. They get a chance to come in our simulation center. We put them through a simulation. They get wonderful webinars by all different speakers from all these different fields, and we give them a stipend. And then one of the programs that ended with them going on a field trip to the CDC. And again, these are for underrepresented students of color that would have generally more barriers to getting into the health professions. And so that's one of our ways we try to eliminate those barriers. And then I started a similar program. I love that program so much that I started one that was just for students in our local area of Washington Heights, where I picked 20 students for a 6-week program. And we went each week for 1 day a week. We had the first one on Health Profession Career Expo. We exposed them all different health professions and had speakers come in. CPR class. So again, we taught them skills and they became certified in CPR. We had a whole class on just health equities and social determinants of health with wonderful speakers that talked about health disparities in cardiovascular health, and an OBGYN doctor that talked about disparities in maternal health for women of color. Then they spent a day with me at a simulation center, and we went through a day in the life of the nurse and had a fun interactive day with using simulation. Then they went with the doctor who I teamed up with and went to her simulation center that was focused on anesthesiology and had practice intubation and suturing and all kind of fun stuff. And then the last week, they actually presented their presentation where they had to present on some social determinants of health and how they would address it using public service announcement. So that was our first year that we did that. And we already have funding to repeat it again this year. So those are just some additional activities and ways that we use our simulation center to give back to our community and to promote DEI.
That is so awesome. And as you were talking, I was watching all the emojis kind of pull up because people were clapping and people were congratulating you on getting the grant, and just so many different activities. It's very inspiring to hear all this stuff. And I like that, it's like you reinforce that theme of like, how are we doing this with the pipeline? How are we getting those early interventions with people? So thank you so much. And again, it's also very inspiring for me, even though I knew we were going to do this, to like hear all these ideas and thoughts. So again, like everyone here, I'm also a continual learner about this. While we're waiting for other chats or questions, anybody has up, or David, wondering if you had any other thoughts before we move on as well.
Well, it's very inspiring to see the things that people are doing. it's especially inspiring for me to see what a younger cohort of prominent leaders in these fields. I've been doing it a long time, so it's really great to see. And I have a lot of people that I've trained and trained others. And I think I know as of a few years ago in Australia, I know for a fact that I had great grandchildren in anesthesia, so to speak. So this is really cool. And I hope that we here on the Center for Immersive and Simulation-Based Learning can work with Tom's group, and Tom and I have been talking about this over the years, and also at our VA simulation center to incorporate some of these new ways of doing things and new things to do with the existing ways we have to do things. So.
Yeah, it looks like Fernando has a thought he wants to add as well, too.
Yeah, I think we're at a time where change is going to have to occur and will be pushed to occur. But I think the problem we'll have is how. And I think the innovation that Dr. Caruso has shown us, and moreover, as a leader and a person that really has committed his life to do the right thing, it really is inspiring to know that person's out there, that technique is out there, and that we have an opportunity to do something that we've never been able to do before, which is, look at ourselves sort of from the outside and get rid of some of the bias and concerns and behaviors we have to allow us to really just be learners. And I think that is the challenge for a medical school. As a dean for a long time, I've worked with a lot of students, counseled them. The issue is, how do you acculturate them to medicine? And unfortunately, that acculturation process is not in our hands. So they get acculturated to things that don't always work with diverse populations. This is an opportunity to break that, to be able to acculturate them by having environments where we can bring out some of the issues that we know impact patients. And I think with Tom's leadership and his groups, this is really, this is like the new physics opportunity to make change. It is dealing with reality that we've lived with for generations, and being able to put something in that will allow us to step back and make ourselves better. So I applaud Tom's work. It's really fantastic.
All right, David, you're next online. And so I wonder, it's like being mindful of the time, and I know you can be concise and particulate, that we kind of wrap up the panel and then send people on their way. So we make sure that we are mindful of everybody's time today. It's just been so fascinating. I would listen to you all talk forever. So, but
Well, I have nothing to say on my own behalf, and it is really interesting to reflect on this over my years, not quite as long as Fernando's, but still quite a while at Stanford. And yeah, I think this is a real challenge for all of us, and for the next generation and the generations to come, is to make the vision that Fernando and that Dr. Bryan have laid out. The rest of the system, even just on our education side, there are so many things that are calling for attention of our students and our faculty to be teaching and to be doing. Our students are heavily engaged on all sorts of other things. So finding the ways to ensure that these activities are seen as or more important than many of the other things that are currently occupying people's time I think is going to be a real challenge. But if people don't step up to try and do that, then it'll never happen. So I think that's the call we need to make to people, and get everybody to do the best they can to make that happen.
Great, thank you. And I just want to invite the rest of the panel, because as we're wrapping up, if you have any other closing thoughts, again, Dr. Mendoza, Dr. Bryant, Dr. Griswold, thank you so much, especially Dr. Bryant, for starting us off with such an amazing and inspiring presentation. This has been just, you know, like I said, very inspiring for me, and I'm sure for others, as we see the claps emojis coming up on the side. But ask you if you have any closing thoughts. Don't want to ask you about your takeaway moments or aha moments, but just any closing thoughts that you have.
Well, I think you heard enough from me. I just want to say thank you again, you know, even for putting on this webinar, and again, keeping DEI at the forefront, even 3 years after George Floyd. It shows that you understand how important this is. And I just want to thank everybody who has attended, and again, leave with, you know, if even one small change, if you can implement something, you know, that's moving us forward in this whole DEI journey. So just want to thank everybody.
Well, and once again, I want to
Okay.
thank you, Dr. Bryant, for you know, your presentations and your discussions, and your sharing with us the journey you've been through, which is inspiring in itself. Thank you again.
I would just add that in my career, I don't think I've seen as much concern about social justice than we have today. And I think as teachers, one wants to engage their students where they are. And right now, the students are here in the area of, let's make a difference. Let me create a career that I can make a difference. And I think helping them understand how that can happen is really important as a teacher, no matter if you're in kindergarten or medical school. And the challenge is, how do we do that? I think this technology, it's so inspiring for change. And I just applaud, David, your foundational work over the many, many years, because I think, you know, you have these trajectories of effort that come together, and this is coming together right at the right time to understand how we enlighten ourselves about how to do better. And I think that's what Tom's, you know, technology is really going to allow us to do. So I would encourage you and others to really push this, both at our schools and across the country, because I'm not sure that they understand the impact or the value. I think they understand the concern of making change, but I think everybody's going to look for how. And this is a great way to do it.
Thank you, Dr. Mendoza, again, for the kind words. And, you know, to reiterate again, I'm just so humbled to be here with you guys today. I would say just some thoughts, not necessarily about our augmented reality directly, but one thing that I often think about and talk to other folks about is that you may not be firmly planted in the DEI space. You may not consider yourself a DEI expert, but to what Dr. Bryant just said, whatever it is that you are good at, whatever it is where you focus your energies, if you think about it, there's probably some way in which you can utilize that privilege and that power and that interest that you have to help push forward these efforts. And that's sort of how we came to where we are within the Stanford Charter program, using that mindset because it is such an important topic. And, you know, at first, some people sort of raise their eyebrows because they're like, well, you guys are using VR to help kids before they get needle pokes. I'm like, true. But with that knowledge, there are other important aspects of the world in which we live in, particularly social health and social determinants of health and health equity. And how can we use our knowledge to help in other areas? And I just encourage all the participants that are here still, the attendees, just try to think about ways in which you can utilize your natural interests to contribute to a larger effort here.
Thank
Well
you,
said.
everybody. Oh, sorry. I should let David wrap up finally and give his concluding remarks.
Well, that's well said, Tom. And I think I'm very pleased to be able to say, I think it was very well said by everybody today. I hope that those of you who have been our attendees have found it as inspiring as we have. And I hope that it's just the beginning of some more conversations and some more activities here and all over the place, as Fernando would have us do, and Tom as well. And it is the reason we do the work that we do. I frequently in my own talks with there's a saying that's so good. It's in both the Hebrew Talmud and the Muslim Quran that whoever saves a life, it's as if they've saved all of what we now would say humankind, not mankind. And that's, you know, I think the same spirit in terms of provision of healthcare applies. You know, no one of us can make every change happen for everyone for all time. But at least if we can do a bit to save lives, hearts, brains, and so forth, and to improve social justice, we will have done an important part, and collectively, hopefully we can all do, you know, an astounding part to make these things happen. And so I'd really encourage everybody who's listening, as was suggested, do what you can do, keep moving forward, work together with other people to try and accomplish these goals. And as I think many of us have learned over the years, perseverance is really critical, because none of this is going to happen very quickly. So we have to be in it for the really long haul. I don't necessarily want to be the last person to speak here, so but I'm done saying what I'm going to say. Thanks very much, everybody, for attending, and for our wonderful keynote speaker and panelists.
And also a special thank you to Carolyn, who kind of ran the magic behind the scenes and made everything happen and organized everything. We just want to give a shout out to her, and to Remy for helping us with the technical stuff. So thank you to everybody who, you know, it does take a village. So we have a wonderful group here that works with us to make this all happen.